Hello, I'm Dr. Niezgoda. Welcome back to AZH Wound Center in Milwaukee, Wisconsin for another edition of the Wound Care Window. A very interesting patient I'd like to share with you today. He was actually seen by his primary care physician after presenting with right great toe swelling and tenderness, and he was referred over to the Wound Care Center. Fortunately, we were able to see him today, and now we're going to share his case with you. This is his examination. This patient is diabetic and does have neuropathy from probably from both his diabetes as well as to a spine issue that gives him a little bit of a foot drop here as well. On examination, his pulses are strong, triphasic by Doppler, dorsal pedis, and biphasic in the posterior tibial region. No other ulcers. In fact, this is his first issue with his feet, which obviously he's very fortunate for. If you look at this area, it is swollen. There's some fluctuance here, obviously. And if I look at it, there looks like there's a little bit of a disruption here. He does not recall any injury to it, but he certainly may have caused a little disruption with secondary bacterial seeding. Infections of the toe, the tissue around the toenail, are called paronychias. There's another term called onychomycosis, but this acute infection is more consistent with the paronychia. Whenever there's pus, obviously this needs to be drained. Most often we see these paronychia on the lateral or medial margins of the nail. This proximal presentation is a little different. Nonetheless, it needs to be drained, and we're going to show you how to do that. So I'm going to go ahead and prep the toe with a little betadine and some alcohol. So we'll paint this with some betadine. Many people will do an IND after just swabbing with betadine. I like to actually remove that with alcohol. As you know, betadine is very caustic, so I don't want that betadine getting into the wound base if I can avoid that. Now, unlike most dermal abscesses that would be incised across the base, for example, across here, we're going to do a little differently. We're going to drain this from the margin of the interface of the nail bed to the tissue. And so we're going to take the blade and we're going to just stick it right underneath. And again, he's neuropathic, so this shouldn't cause him a lot of issues. We're going to get into that abscess cavity, just elevate that tissue on the nail bed. And that should allow us access nicely to the abscess cavity. See, some of that drainage starting to come out already. And there we see the drainage. We'll decompress that. And we'll continue to drain and compress. Remember, we've talked before in prior episodes, we really want to get some good decompression of that pus pocket. Now, he's got a lot of swelling in there, and that'll settle down over time, but I do want to, again, try to milk out anything that could potentially be abscess. And you can see that that area has been decompressed pretty nicely. So now what I'm going to do, after I'm pretty comfortable, I've gotten all the pus out, I want to wick it using a little Hydrophera blue here to wick that abscess cavity. We are late in the afternoon on Wednesday afternoon, so I am going to leave this wick in place and see him back Friday morning. I'm actually going to put a couple wicks in here. So Hydrophera blue is a good antimicrobial and should allow us not only drainage but a little topical antimicrobial effect as well. Okay, good. We've drained the abscess, packed it with some wicks. So I hope you've enjoyed this edition of the Wound Care Window. Very interesting presentation. Not too common in wound care clinics, more often in podiatry offices. They probably do a better job than I do, but nonetheless, we've drained the abscess and the patient should do well. One side note, typically when you drain these, they don't require antibiotics, but based on the patient's diabetic status, I'm going to go ahead and put them on a short course of antibiotics. See you on the next edition of the Wound Care Window.